so I appreciate it even more. This is great. And don't worry, because I cannot stay here beyond 6 p.m. because I'm going to the Atlanta United game at Mercedes-Benz Stadium, so I have to leave by 6, okay? Anyway, so I'm Carlos Franco. I'm one of the partners, the founding partners of Georgia Cancer Specialists, and my expertise is in hematologic malignancies. So I'm happy to say that, not only because that's what my passion is, and it is really a passion because I just love to treat patients with hematologic malignancies, but also because, for some reason, most of the remarkable progress in the treatment of cancer is in the area, or has been in the area, of hematologic malignancies, like chronic lymphocytic leukemia that we're going to talk about today, chronic myelomonocytic leukemia, chronic myeloid leukemia, myelodysplasias, myeloma, large cell lymphomas. All of these hematologic malignancies now can be treated with therapies that are so much better than when I started my practice here in Atlanta 32 years ago. So, even in CLL, I mean, we're talking about CLL, the transformation, the progress, the evolution of the treatment has been truly remarkable. So, when I talk to my partners, my other partners who have since retired, you know, in the last 15, 20 years, sometimes they look at me with a little envy and a little nostalgia, because now I can tell a patient with myeloma, for example, that he or she is not going to survive just 3 years, but perhaps 15 or 20. So it's just a remarkable progress, and I have enjoyed that in my practice, and we'll talk about it with regards to the CLL today. Now, these slides, the slide set was given to me by the cancer support community. It has been reviewed by an expert physician. And this program was developed by the cancer support community. They had medical and psychological experts reviewing it. And they have the control of the program. And it's generally sponsored by Janssen and AbbVie, which are very successful drug companies that produce medicines for CLL. And I have no relationships or financial relationships or affiliation to these companies. So I'm not here because they pay me. I'm not here because they engage me. The cancer support community engaged me, okay? So now, what is CLL, SLL? Now, I think the most important message that I want you to take home with you today is that despite the fact that we're here doing a talk for the cancer support community, and this is a malignant disease with malignant cells, what we call monoclonal lymphocytes, and I will explain that. I have never called it cancer. Never did, never will. There is no need to call this disease cancer. Now, it is a disease of monoclonal lymphocytes. Yes, the lymphocytes, these are cells that are cells in the bone marrow that are produced in the thymus and in the bone marrow. When they become malignant or monoclonal, they are not very effective in fighting infections. They may produce abnormal monoclonal proteins, and they grow very fast. And they basically divide and double very fast. So that is, by definition, a neoplasia, or what we call a cancer. But I have never told a patient with CLL that he or she has cancer. There's no need. Because the outcome, the perception, the prognosis is so much better. And if I see a patient with, better than most of the solid tumors, we have made a lot of progress in the treatment of solid tumors too, yes. I have never dreamed, in 30 years ago, I would have never dreamed that I would be treating lung cancer with immunotherapy, just making the immune system more effective and keeping people alive, people with metastatic cancer, 4, 5, 6, 7 years in immunotherapy, or what we call targeted therapy, and we're going to touch upon the targeted therapy for CLL. Drugs like Tagrisso or Tarceva, for example, for lung cancer that is EGFR mutated. Some mutations that exist in cancer. We can target those. I just had a patient who had 6 years of treatment with this targeted agent, Tarceva. Her disease came back, put her on Tagrisso, the new one, and a year later, she's in complete remission with no evidence of cancer in the liver, in the adrenals, or in the lungs. And she had metastatic disease. So I would have never dreamed when I started my practice 32 years ago that I would have said this in public, I can treat lung cancer with immunotherapy or with targeted therapy and keep people alive. But again, the progress has been more significant or wider or broader in the sense of available therapies for more diseases in hematologic malignancies. But again, I don't call it cancer. Now, many times, and let me explain once again, or with another statement, what I mean. If I have a patient goes to the primary care doctor and has 8,000 lymphocytes, okay? The total white cell count is 16,000 or 15,000. So the patient is seen again 6 months later, and now the white cell count is 20,000 with 13,000 lymphocytes. So the patient is fine, has no fever, has no infections, no night sweats, hasn't lost any weight, great quality of life, 78 years old. So the patient is sent to me because now the primary care doctor says, well, I think that your lymphocytes are higher. I'm a little bit concerned, so I'm going to send you to Franco for a hematology consult. So I see the patient. The patient has no enlarged lymph nodes anywhere. Neck, armpits, spleen is normal. I don't feel a big spleen. Patient tells me that he or she hasn't had fever, night sweats, weight loss, infections. And I do a blood count in my office, and it's 19,000 with about 13,000 lymphocytes. Okay, so I would never mention the word cancer, number one. And number two, my most important message that day for that particular patient is going to be, okay, I think you have CLL, chronic lymphocytic leukemia. I'm going to do the study that will confirm that. Very simple, very inexpensive. It's called flow cytometry. So they put 1 million lymphocytes or white cells going through this ray of light in this machine, and this machine can pick up one abnormal lymphocyte in the middle of 1 million normal cells. So it's a remarkable thing, but it's very simple, very safe. Anyway, so then I get an answer that these are monoclonal lymphocytes that express these markers or antigens in the membrane of the cell, CD5, CD19, CD20. So I know CLL. Okay, so I tell the patient, again, no cancer. I'm not going to mention the word cancer. And then I say, the most important message, put it in the back burner. And that's for most of the patients with CLL that I see, because primary care doctors refer patients to us earlier rather than later. They don't wait until they have 60,000 white cells or 100,000. No, they see lymphocytes, more than 5,000, and so I see many patients that are very early in the course of the disease. And many times I even say, you are 78 years old, you have only 13,000 lymphocytes. It is very likely that you will die with this, not from this. And that is my most important message the first time that I see that patient and confirm the CLL, because it is very unlikely that a patient with 13,000 lymphocytes at 78 will ever get complications from CLL. Not impossible, but very unlikely. So what we're going to talk about today when we get to treatment is mainly the patients that are progressing, the patients that are having increasing blood counts, or the patients that have symptoms or signs of progression of disease. But the majority of patients, number one, will not be bothered by this condition in their lifetime. Number two, will not require treatment. And that's the main reason why I don't call it cancer. I don't want a patient who survived with this word, this hat on their heads, I have cancer. You have a chronic lymphocytic leukemia, which is the most common leukemia in adults, especially in people over 70. And number two, one that many times will never become a problem or will never require treatment. Okay? So, symptoms and diagnosing. Now, I already told you about diagnosing. We do a very simple test, flow cytometry in the blood. We find those markers, CD5, CD19, CD20, and the cells are monoclonal, and they may produce a little abnormal protein that we can measure in the blood, and that's the diagnosis. I don't do bone marrow biopsies. In the past, people did bone marrow biopsies. There's no need. If you have the flow cytometry, unless patient has cells that look more like pro-lymphocytes or cells that you cannot tell for sure in the blood what they are, more aggressive cells, larger cells, then I may do a bone marrow biopsy. But routine, I looked at the blood under the microscope. These are very small lymphocytes that look 100% normal. You cannot differentiate between a normal or an abnormal CLL lymphocyte in the microscope. They look the same. All you have is many more, but they look the same. There's no difference to the eye. Now, if I see something like a bigger lymphocytes, more cytoplasm, sort of unusual looking, what we call less basophilic, the cells are in the cytoplasm around the nucleus of the cell is very dark blue. Now, if the cell is lighter blue or has some white halo on top of it, so there are some things that would make me concerned and would make me do a bone marrow, but that's 1 out of 100 times. For a routine CLL, no need for a bone marrow. Now, communicating with your healthcare team, I communicate with my team, you communicate with yours, your family. Treatment options. Now, we'll talk about it later, clinical trials, and living with CLL, SLL, okay? Now, your loved one may have been diagnosed with cancer. That doesn't mean that cancer has you. Again, in this, it's a very important thing to educate yourself. And I say this because I truly believe that I'm gonna become responsible for a patient's illness, for a patient's condition, and I'm gonna give the best advice I can. But everybody has to be responsible for his or her own health also. And I say that to my patients. You need to educate yourself. You need to find out exactly what you have. Go read it, Google it or whatever, and get some information. And the next time I see you, if you have more questions, I'll be happy to sit down with you and answer all your questions. But many times it's good. My nurses will educate you beyond what I say. My nurse practitioner will do the same. Then you do your part, and then the next time I see you, we'll have another session, question and answer session, so that you are comfortable and put this hopefully in the back burner and go about your life with good quality, emotionally and mentally, without having this cancer thing on your head. Now, chronic means more than 6 months. Acute is now. Subacute, 1 day to 6 months. And then more than 6 months is chronic, something that you have more than 6 months. Chronic is something that stays there for a long time. Okay, so chronic as opposed to acute. If I see a patient with acute leukemia, that patient needs care now, needs treatment now. It's acute now. Chronic is different. May go for months or years without any need for treatment, but it's always there. Lymphocytic, because it begins in the lymphocyte. It's a disease of lymphocytes. There are many types of white cells. The myeloid cells, neutrophils, granulocytes, monocytes, eosinophils, those are myeloid cells. It's a myeloid family. Lymphocytes, we have the lymphoid cells that become plasma cells when they mature. These lymphocytes are supposed to fight viral infections, viruses, and also are responsible for the surveillance of cancer cells. But when they transform into plasma cells, which they are supposed to do, when they mature, they begin producing proteins that fight infections. Those are called immunoglobulins. So the lymphocyte has some responsibility with regards to fighting virus infections and sort of attack cancer cells. But when they mature and become plasma cells, they produce immunoglobulins that are proteins that fight infections. Okay? So, the other main type of leukemia is myeloid. There is a chronic lymphocytic leukemia. We're talking about that today, but there is also a chronic myeloid leukemia. The chronic myeloid leukemia was bad. I remember losing a 30-year-old newly married man who was the manager of the Parkside Cafe at Perimeter, right across Perimeter, in 1990, because he went for a bone marrow transplant at the Hutchinson Center in Seattle and died a month later with complications of transplant. At that point, I had nothing else to do for a young man that wanted to be cured from chronic myeloid leukemia. For that condition, we have also made remarkable progress, and perhaps in the future we'll talk about this in a setting like this. And by the way, I never gave a talk in a kitchen. Never did before, but this is inspiring. It's like after the talk I'm gonna eat. Okay. So we have always made remarkable progress in the treatment of chronic myeloid leukemia. Now we don't have to do a transplant. We just give the patient a pill. He or she takes the pill every day and the leukemia disappears. So it's just remarkable, absolutely remarkable. 30 years ago, I used to just get so upset, so distraught before opening the door to see a patient with CML. Now I go with a big smile on my face. Okay, where is he? Where is she? Anyway, so, and the leukemia means changes in these cells. These cells are now clonal. A lymphocyte is supposed to become plasma cells that will produce all kinds of proteins to fight infection. A monoclonal lymphocyte, a leukemic lymphocyte, may multiply like crazy, but is unable to fight infection. It becomes inefficient. A leukemic lymphocyte cannot fight infection and cannot turn into a plasma cell that will produce proteins to fight infection. It's useless. It just divides like crazy. Okay, so that's what leukemia means. The constant division of these abnormal monoclonal malignant neoplastic cells. But they are useless. No function. They don't function. Again, the leukemias are acute lymphocytic leukemia and the chronic lymphocytic leukemia. Acute lymphocytic leukemia is the most common leukemia in kids, and it's 80-90% curable in kids. Chronic myeloid leukemia, I just told you about, a pill, that's all you do for that. And acute myeloid leukemia, as the word says, acute, you have to treat patients quickly because it's an acute condition, unlike the chronic leukemias. Now, what is the other name? The other name of chronic lymphocytic leukemia is small lymphocytic lymphoma. It's the same disease, it affects the lymphocytes, okay? They are the same disease. CLL and SLL are the same disease. But in CLL, most of the lymphocytes are in the blood and in the bone marrow. But in small lymphocytic lymphoma, the same cells are mostly in the lymph nodes. Okay, so the same cells, the same type of cell, malignant lymphocyte for CLL in blood and bone marrow, for small lymphocytic lymphoma in the lymph nodes. But it's really the same disease. Now, CLL generally is very slow developing. Generally. There are only very few cases of CLL that I've seen in my life that just exploded because they had some abnormal chromosomes that drove the disease to become more malignant and rapidly evolving or rapidly progressive. And I'll talk about that in a minute. But in most people, it's a slow developing disease. Okay? I just saw a patient of mine who is the father of a GI doctor here in town who has seen me now for 22 years. He never required treatment. Okay, so sort of unusual, but it happens. Okay? Now, some people with CLL do not need any therapy right away and may never need medical treatment. Okay? Now, other people will have a form of CLL that grows more quickly and they will need to begin therapy as soon as they are diagnosed with the disease. Unlikely, very unlikely. It is more likely that the patients who begin to progress or evolve or get worse quicker than the patients that are under observation will do so in a year or two. But to come to the office and need treatment right away is extremely unusual. I have seen it, but it's very unusual. It's more likely 1 or 2 years, perhaps 3, depending on the doubling time. How much does it take for the lymphocyte count to double? Or how much does it take for the patient to develop symptoms? If a patient walks into your office and has lost 20 pounds, then your brain begins to boil, because, oh my gosh, this patient's going to need treatment quicker. Or if a patient comes and says, I have drenching night sweats for 2 weeks every night. I get wet every night for 2 weeks. Or I just had pneumonia twice. Things like that, you begin to think about the need for treatment. Most people eventually need to be treated if they live long enough, and now we know. Some days in my office I have a 90-year-old in one room, a 94 in another room, and a 97 in another room. So we may survive way longer than expected. So if we do, for example, if a CLL is producing an abnormal protein, what we call monoclonal protein, there is a probability that it will need to be treated, sometime. If you are 60 and you're diagnosed with CLL with an abnormal protein, and you live to 90, there is at least a 30% probability that you will need to be treated. So it's, so we sort of evaluate those things. But anyway, there is currently no cure for CLL, okay? But it is possible to live a healthy life with the disease and continue to do many of the activities in your daily life. Again, this is the main reason why I don't use the word cancer, and I tell patients, put it in the back burner and let me worry every 6 months when you come to see me and do a blood count, then we'll talk. But in the meantime, the next 6 months, just have fun. Go see the Atlanta United or Mercedes-Benz Stadium. Even if you don't like soccer, you know why? I'm passionate about soccer. I grew up playing soccer, but it's the experience. It is really a remarkable experience. You go in there and there's this 360-degree giant screen, and the restaurants, the club, the lounge, it is an experience. I never experienced that before, and I've been to stadiums all over Europe watching soccer games, and all over South America. I never saw this, and this is a stadium that was supposed to be built for the Falcons, and now the only winning team in Georgia plays there. No, my kids would hate that. But anyway, CLL is the most common type of leukemia in adults. Okay, the most common type. Okay, after that we have CML and AML. Acute lymphocytic is extremely rare. It's mostly seen in kids. But it's CLL, CML, and then acute myeloid leukemia. In the United States, there will be about 21,000 new cases this year. The average age at diagnosis is about 71. It's rarely seen in people under age 40 or in children. No, I did training in children, and I never saw a case. Mostly acute leukemias in kids. I've seen several patients under 40, and I became a good friend with a local attorney who I diagnosed at 37 years of age. Now, I'm sure you understand this. We're all getting older, and if I see a patient at 78, I don't know, the probability that that patient will survive to age 90 is there, but it's small. But the probability that at 37 will survive to age 60 is significant. So you are sort of a little bit more aggressive, not only because those patients are younger, but also because they can take more aggressive treatments, like a bone marrow transplant. It's very unlikely that at 78 you will ever have what we call an allogeneic bone marrow transplant. That's from a donor, from another person. Very unlikely, but at age 37 you deserve one. You need one. You can take one. You can tolerate one. So I treated him for 10 years, and I gave him a treatment that I will not use in 2019. It was the best treatment available when I saw him about 15 years ago. At 37, it's a treatment that was put together by the experts at MD Anderson. Susan O'Brien, Michael Weir, there were another one. There are 3 guys, Jorge Cortez. So all these people put together this treatment program with a drug that is called fludarabine, another drug that is called Cytoxan, and Rituxan. Chemoimmunotherapy, okay? 2 chemotherapy drugs and 1 immunotherapy drug, FCR. Became very famous. Every younger patient had FCR, and If you were under 60 or 65, you would probably get FCR every time. The concern with FCR is that it damaged the stem cells significantly in some patients. And 10 years down the road, they developed acute leukemia. Initially, in the initial clinical trial, it was felt that it was only perhaps 2-3% of patients that developed acute leukemia. So it was worth the effort. It was worth trying it because the risk was very slow. In my practice, it was never that slow. I mean, I have several patients who 10, 12, 13 years on the road developed acute leukemia, or what we call myelodysplasia. So I looked into it, talked to them, the Anderson people. At the end, when we started having targeted therapies for CLL, the percentage was no less than about 8 or 10%. So the percentage was always higher, we just didn't know. But when we started using the drugs in the community, which it always happens, the patients on clinical trials are so tightly selected. When the drugs get to the community, we don't have the selection process. We treat everybody that needs to be treated. And we started seeing more and more cases. So we were more careful, and now I would not, with the availability of the new therapies, I would not offer FCR to anyone, even younger patients, and I will explain that later. But the FCR was the best treatment. More than 50% of patients were in complete remission at 10 years, with no evidence of leukemia. There was nothing better. So you discussed that with patient and you gave the FCR. And then this attorney of mine, with his friend, developed acute leukemia about 12 years after the treatment. I gave him Vidasa, which is a drug that we use in the outpatient setting for leukemia, and then I sent him for a transplant. And transplant didn't respond. He didn't respond to a transplant, didn't do well, and died. So he died at 49, I believe. He was 49 or 50 a couple of years ago. So, I mean, that is always painful when you realize that now that wouldn't happen. I wouldn't give him FCR. I would give him drugs that are safer and easier to give or easier to treat with. And, you know, that's the price I guess you have to pay for doing clinical trials and making progress in treatment of these diseases. Anyway, so, and I have seen others, but I remember that was the youngest, probably 37 in my practice now. Many people with CLL do not have any symptoms. Most people that walk into my office with CLL or for evaluation for CLL have no symptoms or no signs of CLL other than the lymphocytosis. Now, if you come with symptoms, the symptoms that are common are fatigue. You're very fatigued. In fact, it's interesting that many patients that require treatment, sometimes they don't tell you how tired they are. And then you give them treatment, 6 months later, the leukemia is in remission, and many patients look at me and say, "Doctor, I just didn't know I was so tired." So their energy, their quality of life is so good now that they thought it was just daily life and work and whatever. You know, I did not know that I was so tired. Okay. So weight loss, significant weight loss, more than a pound a week, drenching night sweats. This is drenching, wet every night for 2 weeks. A fever without proof of infection or with infection, or anemia or thrombocytopenia. And that's a point that I want to make. Many times patients present with anemia, or patients present with a low platelet count and the lymphocytosis. And that's all. They don't have anything else. They feel fine. Then we have to evaluate the blood for what we call immune cytopenias. The anemia may not be due to the growth of CLL cells in the bone marrow. The low platelet count may not be due to progressive CLL. They may be immune, and that's a common complication. I mean, perhaps not that common. 10%. 10% of people, 5 to 10% of people with CLL may develop an immune anemia or an immune drop in the platelets. Okay, that's an antibody. They form an antibody that coats the red cells or platelets, and when they go through the spleen eats them out. So what happens? All you do is give steroids, a little prednisone, and that goes away, and that improves. You don't have to treat the leukemia. If there is an immune drop in red cells or platelets, all you do is give steroids, and that will go away. Again, you don't need to treat the leukemia unless there is any other reason to treat the leukemia. So the immune anemias or immune drop in the platelets, just steroids. Okay, now, many times the symptoms that we see are caused by something else. You know, for example, I have patients with CLL that have rheumatoid arthritis. Or I have patients with CLL that have uncontrolled diabetes. I mean, you know, there are other things going on. So you need to sort of find out exactly what's causing the symptoms. Now, again, I said that before. If they don't have any symptoms, we do a test, you know, the flow cytometry to see if those lymphocytes are abnormal. Again, sometimes, and this is very, very common, primary care doctors evaluating patients for other conditions or follow up for diabetes, high blood pressure, whatever. And then they do a blood count on a routine basis, part of the routine physical exam, and they find that there are increased lymphocytes. So that's probably the most common way to diagnose CLL, just a routine physical exam for something else. They do a blood count, so they send the patient to us for confirmation. Again, many times patients have no symptoms or symptoms that are related to other conditions. Now, communication is always important. The patient needs to understand very well. There are some people that are able to swallow the news or absorb the news in a more positive fashion, but there are some people that get distraught. I mean, you know, I don't know for sure who is going to react how, so communication is extremely important, making it clear to the patient what the condition is, what does it mean for the rest of their lives, and also to make sure they understand that if they are in early stages, I'm probably the least of their problems. You know, sometimes I say that to my patients. Okay, you come here for CLL, I may be the least of your problems. You also have diabetes, heart disease, have 2 stents in the coronary arteries, or have high blood pressure. I mean, you know, I may be the least of your problem. You come see me every 6 months, but I may be the one that you just come for a blood count and for good news. Okay, so, well, that's always, you know, you will, at least, you know, I think it's very important to make sure you feel listened to make sure that your doctor is answering your questions, and that you are satisfied that someone listened to you by the time you leave the office. That's always very important, even if you have CLL. Obviously, it's going to be more important if you have a cancer that is treated with chemotherapy and that you have to come every week and you're sick with fever and weight loss, you know. But in any event, in order for you to understand that this is something that you perhaps need to put in the back burner, then you need to understand. You need to have your questions answered. Okay, so blood cancers are uncommon diseases. Now, if you come to my office and follow me around treating my patients, then you would think that they are the most common diseases in the world, because this is all I see. But they are, you know, there are 150,000 cases of breast cancer every year. There are only about 30,000 cases of large cell lymphoma, 21,000 cases of CLL. You know, so if you compare 120,000 cases of colon cancer, 100,000 cases of prostate cancer every year, you know, 30,000 cases of follicular lymphoma, or 25,000 cases of myeloma. Yeah, but sometimes I feel that they are all in my office, you know, so anyway. Okay, so, but again, they are uncommon when you consider the other, and also, I mean, it's interesting that what it says here, that you could consider seeing a doctor who focuses on CLL. I don't think you absolutely need that unless you're in trouble with your CLL, but there is a distinction that perhaps you haven't heard that much about. The only reason why the specialty of hematology and oncology is what it is, in most cases, is because there is some overlap, because of the overlap. If you are an oncologist, you may be able to take care of lung cancer, which is a solid tumor, and also take care of chronic lymphocytic leukemia, which is a liquid tumor. So there's an overlap. But the cancer doctor may not be able to take care of an anemia, which is benign, or a drop in the platelets, which is on an immune basis, or other coagulation problems, which are benign. Okay, so what happens is that most doctors that train in cancer medicine have also training in malignant diseases of the blood, and they end up doing both. But there is always a hematology as a single specialty, or a combined specialty with longer training. In order to be a board-certified hematologist, you have to have an extra year of training, not just the 2 years that it requires for oncology. So you have extra training in order to be board certified in hematology also. So that's important in my mind, just to make sure that the one that is taking care of you is not just an oncologist, but a board certified hematologist. I personally, as a board certified hematologist and as somebody that has a passion for blood diseases, when I analyze my brain function or my ability to diagnose one or the other or to practice one or the other, I feel that my hematology mind is in a different place than my oncology mind. I do. I do think that my hematology reasoning is different. It's a little bit deeper and more scientific. Because in cancer medicine, we have a diagnosis of cancer and you have the recipes. You know, all these treatments that are really recipes, Chopar, Folfox, Folfiri, all these names that are just a combination of chemotherapy medicines. Folfiri is a combination of 5-FU, leucovorin, and irinotecan. Folfox is a combination of 5-FU, oxaliplatin, and leucovorin. CHOP is Cytoxan, Adriamycin, vincristine, prednisone. You know, CAT is Cytoxan, Adriamycin, Taxol for breast cancer. So you have all these recipes or names that are combinations of medicines for cancer. But again, I think it's important, again, yeah, I'm not telling you to leave your doctor and go CLL, no. But it's important to have a board certified hematologist for diseases that are of the blood, separate from solid tumors. Okay, I'm not saying that oncologists are not qualified to take care of these malignant diseases of the blood. I'm just saying that there is separate training and separate board certification for the hematologist, separate from oncology. But anyway, so after you're diagnosed with CLL, your doctor will discuss treatments that are best for you, or will just watch and wait, which is for most patients. Your doctor may ask you, what do you want to do? This is called treatment planning. I have to make sure that patients are comfortable with the watch and wait, with the wait, the observation. I have to make sure patients are comfortable. There are some people that are not very comfortable, so it takes longer to convince them, listen, nothing is going to happen. There are many studies from the 60s, 70s, and 80s. Dr. Kanti Rai and other people in Kanti Rai, New York, other people in France and in England that did studies showing that if you treat early CLL early, you live the same number of years. So there is no difference. You don't need to be treated early because that will not prolong your life. And it will give you side effects. Okay, so asked about the goals of each treatment option, including the option to wait to start treatment, which is the most common. Because CLL has a slower progression than other types of leukemia, many patients do not have symptoms or risk factors and don't need any treatment. These patients can be closely monitored but not treated for years with an approach known as watch and wait, also called watchful waiting or active surveillance. Now, many patients with CLL, though, have an abnormal immune system, and I explained that to you before. These lymphocytes are useless. They don't fight infections, or they don't turn into plasma cells to produce immunoglobulins. And when I measure the immunoglobulins on many patients with CLL, they are quite low. And sometimes they have an infection in November, bronchitis, they have pneumonia in December. So what I have to do is give them those proteins in the vein. That's called IVIGG. Infusions of intravenous gamma globulin. If you, especially in the winter months, you begin to have recurrent infections, you need IVIGG if your levels are low. That doesn't mean that I'm treating the leukemia. No, I'm just treating the immune deficiency, what we call the hypogammaglobulinemia, because those lymphocytes are not turning into plasma cells and are not producing immunoglobulins. So many times we don't treat CLL, we just treat to prevent additional infections with infusions of proteins that fight infection called immunoglobulins. Now, during the phase of watch and wait, patients will undergo medical examinations and testing and counseling about infections or other illnesses. Okay? Now, CLL patients are older patients in most cases, and they are more likely to have other cancers. I've had patients with biclonal, rarely, but biclonal diseases, CLL and myeloma at the same time, CLL and prostate cancer, CLL and lung cancer. So that's not unusual. Okay, why? Because of the age that we're talking about. If you're 80 and have CLL and you smoked for 40 or 50 years, you may have lung cancer with CLL. Okay, if your mother had colon cancer and your paternal grandfather also had colon cancer, you may have CLL and colon cancer. So you always need to remember that everything that has to do with surveillance and preventive medicine has to be done when you have CLL. You don't just forget about the rest of the body because you have CLL. Women have to have the mammograms every 2 years from 40 to 50, then every year from 50 to 65 or 70, and then stop, but colonoscopy at 50. I have many people that never had a colonoscopy and they're 57 or 58. So, I've had 2 already, so it's not that bad. They gave you Michael Jackson's gas, and you laugh all the way to sleeping, the propofol. Very easy. So, it's important to do all this. A smoker. Now, that's one thing that I'm always talking about. You're a smoker, you're 65, and you never had a screening CT of the chest? Come on, the government pays for it. The insurance company pays for it. You need to have a screening CT of the chest if you're a smoker. Because if you diagnose lung cancer late, you may die. If you diagnose it early, you will survive. So there are things that you need to remember. Anybody who has one cancer or one malignant condition is more likely to have another cancer or malignant condition than someone who never had a cancer. Okay, why? That's the nature of the beast. We are born with genes called oncogenes that promote cancer development. And also genes that are called tumor suppressor genes that suppress cancer development. If they are in equilibrium, nothing happens. But if the oncogenes activate, boom, the cancer appears. Or if the suppressor genes fail. So, a person that had one cancer is more likely to have another cancer. Okay, now, watch and wait seems like doing nothing, but it's very effective. You treat the patient emotionally and mentally, and immediate treatment, as I said, does not provide any benefit in terms of survival. Also, patients may build up resistance to drugs that may not work later when you actually need it. So you don't want to burn faces yet. You don't want to use a drug that you're going to need in the future. Early treatment comes with some risks, including side effects. And in the case of the FCR that I said before, it wasn't early, he needed treatment. But then 10, 12 years later, gets a complication. So, the decision to treat a patient is based on symptoms and signs. I do the physical exam in one routine visit, and I see that your lymph nodes in the neck are big, axillary nodes, spleen grows. You are very tired. You get an anemia now from worsening leukemia, low platelets, weight loss, fever, night sweats. So it's a few of those or a combination of all of them, generally 3 or 4, and then you sort of do the blood count and then do the immunoglobulin levels, and may or may not need to do a CAT scan. Now, believe me, we do what we can to decrease cost of medical care in this country. I just want to tell you that we doctors represent, you may have heard this, only 4%. Our salaries, our income represents only 4% of health expenses in this country. The rest are drugs, hospitals, ancillary studies, mostly drugs and hospitals. Now, in CLL, we've been told, and this is a guideline that was created by the American Society of Hematology at least 10 years ago. Many doctors used to do a CAT scan every time they diagnosed CLL. Every time, new patient CLL, CAT scan to see there were enlarged lymph nodes. That has been forbidden by the American Society of Hematology. Why would you do that? If you don't feel anything on exam and the patient is feeling well, that's 20,000 white cells. Why would you spend $3,000 in a CAT scan? So there are 20,000 CAT scans that are not done anymore. So we are constantly trying to do that as a society, you know. And anyway, so the decision to start treatment of CLL is also made by looking at blood test results. And a Ford executive that came to see me about 5 years ago, very nice man, who was devoted to his wife with Alzheimer's disease. He looked at me and said, I don't care what you say today. I want to make sure that you hear me from the start. I don't want any treatment. I don't want anything done because I'm going to take care of my wife until she dies. And I don't want anything to interfere with that. And he was serious. I said, blood count, 1 million white cells. 1 million white cells, 800,000 lymphocytes. It was 3 or 4 years before I started treatment after his wife died. Perhaps God's blessings, but he did not have any complication or symptom with 1 million lymphocytes. Okay, that was the first time I ever saw that. I had never seen that before. And he responded beautifully to treatment. He moved out of town to live with his daughter about a couple of years ago. So I treated him like 5 years with one drug called ibrutinib, then Venclex, and he's doing great. But 1 million, I mean, I could not believe that. But anyway, so what does that tell you? That the lymphocyte is very small. Okay, it goes through the blood. It flows with no problem at all. It just flows. Even if you have 1 million lymphocytes, they are so tiny that they just flow. Okay? Now, myeloid cells, on the other hand, the chronic myeloid leukemia, you get in trouble if you get to 100 or 200,000. You're in deep trouble because those cells are big, and they don't sort of, they don't fold or pliable. Is that right? Okay, so they could get stuck in the blood vessel. So you get in trouble. You feel bad. You could have problem in the lungs from those cells sticking to the blood vessels in the lungs. You could have brain. Because those cells are so big. Lymphocytes are tiny, and they usually do not cause trouble because they are very small and they just flow. Okay, so let me see. Okay, the goals. The goals of treatment are slowing down the growth of the CLL cells, maintaining your lifestyle, keeping you feeling well enough to carry on the day-to-day responsibilities. Remember the guy that told me, I did not know I was so tired because his life was so good now on treatment. Bringing your white blood cell, red blood cell, and platelet counts to normal levels. Remember, when you start producing too many lymphocytes, you quit producing normal numbers of red cells and platelets. So it's not unusual to see now an anemia or a low platelet count from overproduction of lymphocytes. Not immune, as I said before, but overproduction. So that's important. Note that unlike treatment for some other cancers, treatment for CLL is not intended to cure. Again, I cannot tell you that I'm going to cure your illness, but if you are 82 and you're studying Imbruvica or Venclex, the new drugs, I'm not going to tell you that I'm going to cure you, but I'm going to tell you that you will survive until something else kills you. Because it's not going to be CLL with the new drugs. Okay, so anyway, even if there are no signs of leukemia after treatment, it is very likely to come back. But now with the new drugs, we're seeing longer remissions. Okay, we just pills. We see long remissions. At some point, a treatment may begin again. Most people with CLL are treated on and off for years. If you are 60, you're likely to get at least 3 or 4 different treatments over 20 years. If you are 82, you may have only 1 or 2. Currently, there is no cure for CLL, but treatments that control the disease and manage symptoms are now much better. More and more people are living well. In addition to watch and wait, we have immunotherapy, 3 drugs actually. One is called Rituxan. The other is called Gazyva, which is just a stronger Rituxan, about 30% stronger. And also Azera. So 3 immunotherapy drugs. What do they do? I told you before that the 3 most important markers or antigens in the membrane of the cell are CD5, CD19, CD20. The immunotherapy drugs, these 3, bind to CD20. When they bind to CD20, they internalize and kill the cell. So they just have to bind to the CD20 receptor. So that's why they call it immunotherapy. It's an antibody against the CD20 receptor in the lymphocyte. Now, chemoimmunotherapy is the combination of a drug like Trianda or bendamustine. I have to tell you this because it's really fascinating. I'm wasting time, but anyway. Trianda, bendamustine, is a drug that was designed or discovered in East Germany in the 50s. The East Germans never told the West Germans about Trianda. And they were having amazing responses in CLL and indolent lymphomas in East Germany with Trianda, with bendamustine. The West Germans did not know about Trianda until the wall came down in the 89, 90, or 91, I would say. One of my good friends he's an investigator at the University of Frankfurt. And so he went to the laboratories and to the hospitals and the cancer wards in East Germany. And they discovered this. They brought it back to West Germany, and they developed it, and they found that it was the most effective and less toxic drug. It was a combination of two different medicines and into one. And they found it was the most effective drug and least toxic for the treatment of lymphomas, follicular lymphomas. And then they started the CLL trials. It's called bendamustine. So I thought it was an interesting story because, I mean, these people are behind the Iron Curtain and they're having success with this treatment, and the West Germans don't know about it. But anyway, so that's one of the good things about the world coming down. Anyway, so now targeted therapy, these are the new drugs. Venclexta, ibrutinib, idelalisib, duvallisib. There are 3 different mechanisms of action. I'll tell you later. And new treatments in clinical trials like CAR T cells. CAR T cells is a way to stimulate your T cells, your T lymphocytes, which are cells that fight cancer. In vitro, outside your body, they are stimulated and they are brought back into your body to fight the leukemia. Very effective in myeloma cases, CLL, large cell lymphoma, in patients that have no other hope, but very toxic. I mean, you may get your CAR T cells, and then the next day you don't know where you are, you don't remember your name, and you can't walk. But hopefully you improve with a lot of neurotoxicity, a lot of brain toxicity. But, patients are improving when they had no hope otherwise. So, and this is also an immunotherapy type because it's your own immune system, the T cells that are fighting your cancer after being trained outside the body to fight your cancer. Now, a treatment regimen can be a single therapy, just one drug, or a combination, generally 1 or 2, and repeated in cycles. Now, a question to discuss with your doctor: how much experience do you have in treating CLL, the insurance cost? Unfortunately, there are some patients that do not have great drug coverage, and they have a high copay or a high deductible at the beginning of each year. These drugs are expensive. The new ones, everything is expensive. So, I think that's something that some people have to deal with, unless you have a good secondary insurance or full coverage. Okay, oncology nurse or social worker that you can talk to, support services for your family. But again, this is mostly for more aggressive situations or when CLL needs treatment. But at the beginning, it's very little you need to do with regards to all these, things that other people would have to do sooner rather than later. Up to date with treatments and clinical trials. That is when you need treatment. Can you recommend a CLL expert for a second opinion? Well, I always welcome a second opinion. I don't have any problem with second opinions. I think that if you have a significant problem, a significant disease, this is your life, you should decide what is best for you. Planning treatment for CLL, you have to, usually a diagnosis, CLL is low. There are 2 ways to classify or analyze the risk or stage patients. 0, 1, 2, 3, 4, that's an old staging system from Kanti Rai, New York. He's an Indian doctor who started it all in terms of the CLL research. He's almost 80. He's about 80 now. Yeah, he's a good man. But anyway, also there's another Binet, was another expert in France who had the ABC classification table. But anyway, so now we are saying low, intermediate, and high. We don't treat anybody with low risk. Intermediate, we may still watch. High risk is when patients are really progressing, not only with abnormal, with anemia, low platelets, high lymphocytes, fever, night sweats, big lymph nodes or spleen. Those are high risk you need to treat. But the most important thing is abnormal chromosomes. Now we are at a point where we study the cancer cells or leukemia cells at the molecular level, where not only in the cytogenetic level, they growing this chromosome, we're also at the molecular level, we can find abnormal mutations or abnormal chromosomes that are associated with poor prognosis or with better prognosis in many diseases, including CLL. For example, this is a killer. This is bad. If you have a TP53 mutation or a deletion of 17 chromosome, the TP53 gene is in chromosome 17. That's bad. That makes your leukemia grow fast, the myeloma grow fast, the breast cancer grow fast. Anywhere where TP53 is mutated is bad news. Okay, so if you have a TP53 mutation, you're going to need treatment sooner rather than later. Your disease is going to progress or get worse sooner rather than later. You're going to need treatment sooner. Again, symptoms, the molecular testing. Again, we're now at a point that we do NGS. Those are genetic testing of cancer. We're doing it right and left for every cancer because we don't want to miss any opportunity. There are about 5 or 6% of lung cancer patients that express a gene that is called BRAF. If you don't test, you don't know that. The patient may have run out of options for lung cancer. So you do the genetic testing, you find a BRAF mutation, now you give the patient pills for melanoma because of the BRAF expression. So what the message I want to tell you is that now we are able to test the genetics of the cancer cells at a deep level, at the molecular level. And we can find therapies that we didn't know about before. Why would I use a melanoma treatment for a lung cancer patient? If you find a melanoma mutation, you do. So the molecular analysis of any cancer now is extremely important. We're testing right and left to make sure that we offer therapies that may not be available for a particular cancer because they are approved for another cancer. But if we find a mutation, we use them. Okay? So let me see. You can the Leukemia and Lymphoma Society is always a good resource. Again, chemotherapy in CLL is almost always combined with immunotherapy, but we may be getting to the point where chemotherapy is not used for CLL anymore. Okay, the only drug that we're using now, which is chemotherapy, is Trianda, the East German drug. Still using it in some cases in combination with immunotherapy, Gazyva or Rituxan. But the new clinical trials with the newer drugs are so amazing, so remarkable, 80-90% responses, that some people are beginning to use the new targeted therapies without using chemotherapy. So if you are 60, you may see Trianda, Rituxan first, chemo, immunotherapy first, and then later the new drugs. But if you are 78 or 80, you may not see chemo. You may just see Venclexta, Duvalisiv, the new drugs that are not chemo, just targeted therapies. But I will tell you a little bit about these drugs. Now, again, FCR is gone, in my opinion. I don't want to talk about it anymore. There is a drug that is called chlorambucil that some people still use. It's a pill that was used in the 50s and 60s for ovarian cancer. And now, it has been used in CLL in combination with Rituxan or Gazyva, immunotherapies. But again, this is a chemotherapy drug, and with the availability of the new targeted agents that are oral agents, I don't use it anymore. I think the last time I used it was 2 years ago. Anyway, again, the bendamustine is the East German drug. And unlike standard chemotherapy drugs, targeted therapy drugs bind to a receptor in the lymphocyte. So we're not talking about damaging the DNA or the RNA of the nucleus, which is what chemotherapy does. And by doing that, you may have complications in the future from chemotherapy, but also you damage normal cells. The problem with chemotherapy is the damage of normal cells, not just the leukemia or cancer cells. Okay, we don't want to do that anymore. Okay, again, here, limit damage. We don't want to damage healthy cells, which is what chemo does. With the new drugs, we don't do that. These are the new drugs. Some of these bind to a receptor in the B lymphocyte. It's what we call the B cell receptor. There is a receptor that makes the cell grow and makes the cell divide. It's called B cell receptor. These drugs here bind to the B cell receptor. There is ibrutinib. There's another one. It's called acalabrutinib. It's a new one. Ibrutinib and acalabrutinib. Now, I have several patients that have taken ibrutinib now 4 or 5 years. It's still in remission. There are two problems though, and I have seen them, so rare but could happen. My first patient on Imbruvica, on ibrutinib, bled in the stools and in the urine to a hemoglobin of 5. Profound, severe anemia. Started bleeding like crazy in the urine and in the stools. Had to give her blood transfusion, stop the ibrutinib. Why? In some patients, it causes a significant dysfunction in the platelet function. It basically gets rid, it eliminates platelet function. The platelets are the cells that begin the clotting of the blood. They have to stick together in order for the clot to accumulate around the clotting factors. But the platelets have to stick together first. And in some patients, this drug causes significant problem with the platelet function. And the platelets do not stick together and patients bleed. Extremely rare. I have treated at least 30, 40 patients with Imbruvica over the last few years, several years, and one major bleeding. Now, I had another patient that had a lot of bruising, but no bleeding. So, extremely rare, but that's something you need to watch for. Now, number 2, atrial fibrillation. Atrial fibrillation is an arrhythmia of the heart that is not uncommon in patients over 70, 75, if they have heart disease or they have coronary disease or just, just aging calcium and cholesterol in the blood vessels around the electric system of the heart. So some people have AFib, and if they have atrial fibrillation, they are taking blood thinners. So you need to be careful. You may not want to use Imbruvica if the patient is taking blood thinners. You may want to use Venclexta, and I'll talk about that later. Imbruvica may cause atrial fibrillation too. I have a couple of patients who developed atrial fibrillation on Imbruvica, but they had had such a great response that I kept them on Imbruvica, so the cardiologist took care of the AFib, pacemaker or ablation, and they're fine now, or they're taking blood thinners doing well. So we have to make individual decisions if that happens. But that's another risk. Bleeding and atrial fibrillation, those are the main risks. Idelalisib, very effective, but in the initial experience in the community, after the clinical trials said that it was great to use it, we saw a lot of pneumonia, a lot of inflammation in the lungs, what we call interstitial pneumonia, interstitial pneumonitis. We had to use higher doses of steroids in these patients to get them better. So now there is, CMV infections also, cytomegalovirus infections on idelalisib. So sometimes when the drugs get to the community, we are the ones who discovered the main problems that were not seen in clinical trials because the patients were highly selected. So, and then venetoclax, Venclexta, is an amazing drug. I call it the broad spectrum antibiotic of oncology. You can use it in every disease. It has this effect on hematopoiesis and division of cells in the bone marrow. It's truly amazing. It works it could be effective in myeloma, in indolent lymphomas, in mantle cell lymphoma, in chronic lymphocytic leukemia, in acute myeloid leukemia. So a bunch of, in myelodysplasia, high-risk myelodysplasia in combination with Vidasa. So in most of the hematologic malignancies, you can use Venclexta when you have no options because it's not approved for everything. It's only approved for CLL, and I believe it's follicular lymphoma also. Anyway, but it's a remarkable drug. The main problem with Venclexta is what we call tumor lysis syndrome. If you use it in high dose at the beginning, when the patient has a very high white cell count, it could cause release of so much uric acid from the dying leukemia cells that uric acid goes to the kidneys and messes up the kidneys, damages the kidneys. That's what we call tumor lysis. Now, in order to avoid that, you have to start Venclexta at a low dose and build up slowly. But it is extremely effective. The dose is 400 milligrams daily, the maximal dose. The 4 executive that I talked to you about got to 150 in complete remission. Why would I go to 400 if at 150 is in complete remission? No leukemia with 150, so I just left him on 150. But the indication is up to 400. You can go up from 20 to 400. But it's remarkable. There are literally no side effects. With Imbruvica, we could also see some diarrhea. With the dialysis, we could also see diarrhea, drop in the blood counts. You watch the blood counts because with these drugs, you know. Now, what is now the standard of care for most elderly people, and don't ask me what elderly means, because in clinical trials they call elderly even patients that are between 60 and 65. So I take issue with that because I don't feel elderly. You know, I'm over 60 and I don't feel elderly. But anyway, they say that for elderly patients, whatever that means, the upfront treatment could be Imbruvica as a single agent or Venclexta with Gazyva in combination. It's an excellent combination. The problem with Imbruvica is that you have to treat the patient forever. You don't know when to stop. And I have seen patients who, for whatever reason, stopped, and within a week, they exploded with lymph nodes like this in the neck. So if you stop quickly, you may have a problem. But you don't know when to stop. It's supposed to be done until the disease becomes resistant or until the disease reactivates again. As opposed to Venclexta Gazyva. The clinical trial of Venclexta Gazyva was a limited treatment for 1 year. So you can do Venclexta orally, Gazyva every month, infusion, and stop at 1 year if the patient is in complete remission. And that is now has become the standard of care. So many patients are not going to have chemotherapy. Many patients don't need chemotherapy. Now, there are many other drugs on clinical trials. It's truly amazing the number of drugs that we have on clinical trials for hematologic malignancies. But again, we are in the era now where we can use targeted therapy with immunotherapy. My last, monoclonal antibodies are the type of immunotherapy I told you before, Rituxan, Azera, Gazyva. Let me tell you what this lady is a librarian in one of the Catholic schools here in town. And she had been with me for about 2-3 years after diagnosis of CLL. She had breast cancer about 5 years ago. She's still taking the medicine, the pill for breast cancer, aromacin. Comes to me with CLL. And I said, you don't need treatment right now. But about a month ago, she developed symptoms, elevation of the white cells, big lymph nodes. So I started treatment with, I told her about the new treatment, immuno-targeted therapy, no chemo. So the immuno-targeted therapy with Gazyva Venclexta, you give Gazyva first, the immunotherapy. And you give an infusion 2 days in a row, then once a week for 2 weeks. And then you go to every month, okay? So she is in the 2-week phase. She went from, she hasn't started the Venclexta yet. She went from 134,000 white cells to 4,000 white cells today. And she had only had 3 infusions of Gazyva. So immunotherapy may extremely effective, but it's not going to keep it in remission for a long time. So you have to add the Venclexta, but it's truly amazing. And the most important thing is that this lady, despite the destruction of the red cells, the lymphocytes with immunotherapy, did not develop the tumor lysis in the kidneys. So did not have any kidney damage despite the massive destruction of lymphocytes. So immunotherapy is not likely to cause tumor lysis. Venclexta could do it more often. But anyway, so what I was trying to tell you is that immunotherapy by itself may be great if you want a quick response. Okay, but at the end, if you want the patient in remission for a long time, you have to add the targeted therapy. And I think I'm going to stop there because I want to have some time for questions and answers. So thank you so much for coming. And if there is any question, I'll be happy. Oh, perhaps one more thing. The only transplant that you can do in CLL is allogeneic transplant. In a younger patient, we have tried it a couple of times. It's not likely to work in most patients. We generally do it in patients that have no other options And we did it before the era of targeted therapy. So I don't believe we're going to be using transplants anymore in CLL because they are fairly ineffective, very toxic, high mortality rate, but also because we have the other immunotherapy that I just talked to you about, the CAR T cells, where they train the T cells outside the body to fight the CLL, and you give it back to the patient with the fighting abilities now. So that's called CAR T cells. That's more likely to work than a transplant. So, okay, any questions? Yes, go ahead.
So do they automatically